Hello, and welcome back to the MI Mental Podcast, Doctors in Court edition. I'm your host, Dr. Sabine Fonderson. In this episode, I'm going to dive into another real life medical case that led to a disciplinary hearing for a doctor. This case involves a young patient who presented to the emergency department with sudden severe headache, and the decisions that were made or not made during that visit ultimately led to tragic consequences. I'm going to break down the timeline of events, the plaintiff's and defense's arguments, and the final decision handed down by the disciplinary court. And just to be clear, the names used in this podcast are fictional to protect the identities of the parties involved, but the case itself is based on real events. Let's start with the timeline. In November 2006, the patient, who I'll call Mr. Smith, began to experience severe headaches at around 1 p.m. And by 4 p.m., he had visited his local general practitioner out of hours office who suspected fatigue, migraine, or an ear infection. The pain worsened, and Mr. Smith, along with his family member, decided to visit the emergency department around 4:30 in the afternoon. At around 5:15, after waiting quite a while in the emergency department, Mr. Smith was seen by a medical doctor who was also serving as an assistant doctor in the emergency department. This was where the first significant decisions were made. The doctor, I'll call her Dr. Blue, took a brief history, conducted a physical examination, and diagnosed Mr. Smith with a likely migraine. She prescribed painkillers and told him to follow up with his own general practitioner if symptoms worsened. About an hour later, Mr. Smith, still in intense pain, collapsed in the parking lot outside the hospital. He was immediately returned to the emergency department where a CT scan revealed a massive brain hemorrhage. And sadly, despite efforts to treat Mr. Smith, he passed away several days later in hospital. The core of the complaint revolves around Dr. Blue's diagnosis and whether she took the appropriate steps to rule out more serious conditions, such as a brain hemorrhage. Now let's take a look at the plaintiff case. Mr. Smith's family filed a formal complaint against Dr. Blue, arguing that the diagnosis of migraine was made too hastily, without sufficient investigation, and without proper consideration of other potential causes for the severe headache. The family's argument was that Dr. Blue did not perform a thorough enough physical exam. Although she noted that Mr. Smith had photophobia and a stabbing headache behind his right eye, they claimed she missed more serious symptoms that should have triggered further investigation. The plaintiff's team argued that given Mr. Smith's age and the sudden onset of the headache, migraine should not have been the first diagnosis to be considered. They argued that conditions like a brain hemorrhage should have been at the top of the list and that Dr. Blue should have ordered more diagnostics tests right away. And the last argument, delays in treatment. Another key part of the complaint was the delay in Mr. Smith being re-evaluated. After being sent home with the migraine diagnosis, his symptoms worsened, and it wasn't until he collapsed that he was seen again. The family argued that this delay cost him his life, and had he been treated sooner, he could have been saved. Let's look at the defense now. Dr. Blue argued that she had conducted a reasonable examination given the information available at the time. Based on the information available, intense headache, nausea, photophobia, it was reasonable to conclude that Mr. Smith had a migraine. She noted that the physical examination did not show any neurological deficits, which would have been a red flag for conditions like a stroke or brain hemorrhage. In her defense, Dr. Blue said she was doing what she thought was best, given the symptoms and the fact that migraines are a common condition. She mentioned that if the patient had shown more alarming neurological symptoms, she would have taken a different course of action. Before we continue with the court's decision, let's quickly discuss some key medical terms here that are essential to this case. A migraine. A severe headache often accompanied by nausea, vomiting, and photophobia, and that's sensitivity to light. Migraines are typically recurring but can be treated with pain relievers. Brain hemorrhage. That's a condition where there's bleeding in the brain. This can happen suddenly and cause neurological deficits such as paralysis, vision problems, and severe headaches. And a CT scan is the most common test used to detect brain hemorrhages. Photophobia. That's when you're sensitive to light, often a symptom of migraines, but also a sign of some serious condition like meningitis or intracranial bleeding, which is why it should be investigated thoroughly when a patient presents with severe headaches. Now let's talk about the disciplinary decision. After reviewing the case, the court determined that while Dr. Blue's actions were not criminally negligent, she did fail to conduct a thorough enough examination. And the court noted that, especially in cases of sudden severe headache, doctors must consider more than just the most obvious diagnosis. And Dr. Blue, in their opinion, should have expanded the differential diagnosis to include more serious conditions like a brain hemorrhage. And the court found that a CT scan or further neurological test should have been ordered immediately given the nature of the symptoms. And the disciplinary board concluded that Dr. Blue had made a clinical error by not performing a more comprehensive assessment. However, they took into account the chaotic nature of the emergency department and Dr. Blue's inexperience. As a result, the court decided on a warning rather than more severe sanctions. They also acknowledged that the protocols at the time weren't as structured, which may have contributed to the delay. And let's think about this for a second, because this case brings up some really important questions. What is the balance between being thorough and acting quickly in an emergency setting? And should we always run for every test, even if the symptoms don't fully support it? This, for me, is a tough one. I've worked in emergency medicine, and I know how important it is to diagnose things on time. But so is ensuring that we don't miss something life-threatening. And it's really about finding that balance. In an emergency setting, they have access to more facilities. I think should have been the red flag at that point, and this is based on my experience, is that when he was discharged, he was still in intense pain. And I've made it a rule for myself, I do not let people go home anymore if they're still in pain, because anything that you give to them should have an effect. And if painkillers that you give in the emergency department don't have an effect, that's when you need to call somebody else, a specialist, and say, hey, listen, I've tried what I could, it's not working, please go ahead and examine further. How should medical students or junior doctors handle cases when they're uncertain but under time pressure? Well, for me, obviously, as a doctor, I've gone through that whole phase of being a medical student, a junior doctor, and I built up over 20 years experience in medicine. And the lesson here is that it's essential to keep on asking help when needed and to trust your instincts, even in a busy setting, especially, again, red flag, if a patient is still in pain and you've given them medication which you know should make the pain go down. That is already a red flag. So trust your instincts and ask for help. Before I leave you to reflect more on this case, I want to bring in some valuable insights from a critical article I came across entitled Misdiagnosis of Acute Headache, authored by Jonathan Edlow and published in Emergency Medicine Clinics in 2024. This article really sheds light on the complexities of diagnosing headaches, especially when they present in emergency settings, where time and precision are critical. The first point Edlow makes is that while primary headaches like migraines and tension-type headaches are very common, secondary headaches, which can be life-threatening, are often overlooked. And secondary headaches are caused by more serious underlying conditions, and these include subarachnoid hemorrhage, stroke, brain tumors, and cerebral venous sinus thrombosis, all of which require immediate treatment. Now, here's where it gets interesting. While primary headaches are often benign, secondary headaches account for a much smaller portion of the cases but are far more dangerous. The challenge for clinicians is differentiating between these two types of headaches, and the article emphasizes that secondary headaches are often underdiagnosed, which leads to delayed treatment for potential life-threatening conditions. One of the key messages Edlow highlights is the importance of recognizing red flags in patients presenting with acute headaches. For example, a thunderclap headache, which is defined as a headache that peaks in intensity within seconds or minutes, should raise suspicion for subarachnoid hemorrhage, which is a medical emergency. Now, subarachnoid emergency is typically caused by the rupture of an aneurysm in the brain, and immediate imaging, such as a CT scan, is critical for diagnosing this condition, but not all cases of subarachnoid hemorrhage are easily detectable, especially if the hemorrhage is small or if the CT scan is performed too soon after the headache onset. Similarly, the article discusses other life-threatening causes of acute headaches, such as reversible cerebral vasoconstriction syndrome, arterial dissection, and brain tumors, all of which can present similarly to more common headaches like migraines. For instance, migraine headaches are often characterized by severe throbbing pain, nausea, and light sensitivity. But patients with conditions like reversible cerebral vasoconstriction syndromes or cerebral venous sinus thrombosis can also present with similar symptoms. And this overlap is what makes headache diagnosis so challenging and underscores the need for careful evaluation and consideration for other conditions. And what's most fascinating from the article is the discussion around the diagnostic tools we commonly use, like CT scans. While a CT scan can be a quick and reliable diagnostic tool, Edlau points out that CT scans have limitations when it comes to diagnosing certain causes of headaches, such as cerebral venous sinus thrombosis or low pressure headaches, which is where lumbar puncture (LP) becomes invaluable, especially when CT scans don't reveal anything abnormal, but the patient's symptoms are concerning. A lumbar puncture can detect signs of subarachnoid hemorrhage if a CT scan is negative, but the suspicion remains high. Clinical examination also plays a crucial role, and Edlau emphasizes that while the physical exam might seem straightforward, it's imperative to assess for neurological deficits. Symptoms like nausea, vomiting, and photophobia, sensitivity to light, are common in primary headaches, but they should raise flags when associated with more severe findings like visual disturbances or neck stiffness, which could point to conditions, for example, such as meningitis or intracranial hypertension. Here are a few key takeaways from the article. Differential diagnosis. It's essential to not just diagnose a headache as a migraine, but to carefully rule out other possible causes. Some serious causes like brain tumors can present with a relatively normal neurological exam early on, which makes early and comprehensive evaluation critical. Risk stratification. A structured headache risk stratification tool can help physicians better determine which patients are at a higher risk of secondary causes of headaches, and this can help guide decision-making around whether to order imaging or further tests like lumbar puncture. Effective communication and documentation. Edlau stresses the importance of documenting clinical reasoning thoroughly. In legal terms, failure to communicate the risk stratification process and rationale for decision-making can open the door for medico-legal challenges, especially in high-stake cases like a missed brain hemorrhage or a stroke. Key tests to consider. Apart from CT imaging, the article points out the need for MRI scans for patients who are high risk for cerebral venous thrombosis or brain tumors. Also, lumbar puncture should be used when there's suspicion of conditions like meningitis or subarachnoid hemorrhage. The article concludes by reiterating that although migraines are common and usually not dangerous, healthcare providers should always remain vigilant and consider the broad spectrum of possible causes. We're not just treating symptoms, we're assessing for underlying causes that could mean the difference between life and death. And in the end, Edlau's review reminds us of the importance of thorough examination, clear communication, and clinical suspicion. As healthcare providers, we must balance our clinical insights with the appropriate diagnostic testing to ensure we don't miss something critical. A misdiagnosis of something as serious as a brain hemorrhage could have severe consequences. So being diligent in our approach to headache diagnosis is non-negotiable. Thank you for joining me in this deep dive into a real medical case and its legal implications. A misdiagnosis can have serious consequences, but it's also important to recognize that we all make mistakes, and sometimes the systems we work in contribute to those errors. If you enjoy this podcast, please subscribe, leave a comment, and let me know your thoughts on how we can improve clinical practice. Until next time, take care and keep on doing what you love.